Key populations account for 39% of all new HIV infections in sub-Saharan Africa. The World Health Organization recommends prioritizing key populations in countries' HIV response strategy as a way to lower this number. While a number of countries program for key populations and conduct population size estimation, the success of these efforts rests on the ability to plan well and empower key populations. If these two ingredients are missing, the most vulnerable key populations will fall through the gaps and be left unaccounted for. Community-led outreach is a key strategy to ensure that peer educators and outreach workers link their peers to information, commodities, and services at the time and place where they need these most. Through community-led outreach, the outreach team builds trust among the key population peers and motivates them to join the program. To make community-led outreach more effective, a set of tools was developed to ensure that needs-based services and interventions reach these populations. Planning incrementally and at the smallest level, microplanning makes it possible to collect data in locations where key populations are available and use the data to tailor programs that address the needs of these communities. The microplanning process was initiated in India through the Avahan project supported by the Bill and Melinda Gates Foundation. Since then, the tools have been used by key population programs in Kenya, Zimbabwe, and Malawi. It is estimated that Kenya has more than 190,000 female sex workers, 60,000 men who have sex with men, 25,000 people who inject drugs, and 4,500 transgender people. The use of microplanning tools in Kenya has helped scale up contact coverage of key populations across counties. Microplanning tools have also empowered peer educators to plan for the sites and populations that they are responsible for. In Zimbabwe, the HIV prevalence in men who have sex with men (MSM) is 17.1%, while it stands at 60% for female sex workers (FSW). Admittedly, key populations have a higher HIV burden than the general population. To address this, the national program in the country trains key population peer educators to use the microplanning tools to plan for services, assess gaps in programs, and engage in collaborative solution creation with key populations. Malawi has also taken up microplanning specifically for sex workers and men who have sex with men. Using microplanning, the community outreach team extends support to key populations who have high risk and vulnerability. Microplanning helps the outreach team to understand the needs and preferences of the key population and avail services in a confidential way while focusing on those who are generally left behind. Although a number of countries have adopted microplanning, there still exists a large gap in its implementation across the continent. Part of this comes down to a limited understanding of the microplanning tools and limited peer-to-peer learning. This series is intended to bring that knowledge home so that the community-trusted platform in a key population program is effectively used to reach all subpopulations and provide services according to their needs and preferences. When programming for key populations, the starting point is the locations where specific communities come together. For instance, this could mean sites or spots where key populations inject drugs, solicit clients, or cruise. The specific tools to microplan at these locations include A. Site load mapping, and B. Site analysis. The location-specific tools work best if programmatic mapping and population size estimation have already been done. The program team then goes to each of the sites where key populations frequent and uses the location level tools to validate and collect information for planning outreach. However, these tools can be also used to map and estimate the population size where such data is not available. The first location-specific tool is site load mapping. For site load mapping, the outreach or program team requests peer educators or key population volunteers at the site to draw a map of the location where key populations congregate. The map details the streets, buildings, and any major features of the location. In the map, the sites and spots where key populations can be found are marked, and then details of the number of key population in each site is documented and differentiated between normal days and peak days, with peak days being days like Friday or Saturday, when a higher number of key populations congregate in that site. Site maps can be simple, where a map shows where the site is located and how many key populations are there in the site. But they can also be very detailed, even using color codes to differentiate vulnerability levels, like in sites where there is higher violence, and even using removable stickers to represent key population movement between sites. Ideally, these maps should be developed every 6 months to offer the best representation of key population sites in the location.
There are so many things that we need to consider when developing a site map. The first thing is we need to make sure that we have adequate information around the sites. We need to understand what key features are within that location. We need to know what health facilities are around, police services, basically all structures that are very important for key populations. We also need to understand where the hotspots are located. But beyond that, there are also other elements that need to be thought through. Peer educators are developing this site map. Do they understand all the information that they require? This process needs to be done by a peer educator, someone who is doing the work on the ground and not anyone senior within the program. But beyond that, when developing this site map, we also need to be very cautious of the fact that this is very sensitive data, because you're basically listing places where you're going to find key populations. In some country contexts where legal environments are very difficult, this could actually jeopardize the whole program if we're not careful. So in how we keep the information after we draw it, after we develop it, is also very important. So 3 things: security of the information that you're developing, information about the location that you're about to draw, but also making sure that it's peer-led, it's a peer educator doing the work. So the first challenge that is there is when you're developing a site map, you're talking about a hotspot that could change anytime. So today it's active, tomorrow it's not active. You're talking of a site perhaps that today has got younger sex workers or younger key population. Tomorrow the dynamics change. So the biggest challenge that is there is the changing nature, the changing dynamic of hotspots. And how we navigate around it is to make sure that the process of doing this site mapping is done at least at minimum every 6 months, so that we have updated information and updated maps, and we are putting into considerations the changes that are happening within the hotspots.
After site mapping is complete, what follows is site analysis. It builds on the information on the map with the goal of planning efficient outreach. Site analysis considers 5 aspects at the site level that would affect outreach. Typology. This is the classification of key populations into categories based on settings in which they solicit, cruise, or use drugs. Partner or injecting volume. This refers to the number of clients that key populations visiting the site have, or alternatively, the number of injecting episodes for people who inject drugs. Age. Key populations below 24 years are categorized as young, while those 25 years and above are identified as older or mature. Day. This considers whether key populations frequent the site on a daily or a weekly basis. Time. Takes into account the hours in which they frequent, morning, afternoon, evening, or night. After the site mapping is complete, the outreach team, together with peer educators and key population volunteers, analyze the site to understand its profile to plan outreach. This analysis begins with population size estimation for the sites, which can be derived through the size estimation exercise or the site load mapping exercise. Once a site population size is known, the team lists out the typology of the site. For example, if Site X has an estimated 50 female sex workers and the typology of the site is club, Then through the tool, the teams list out the number of sex workers among the 50 that are high, medium, or low in partner volume, the number of sex workers who are young or mature, the number of sex workers who visit the site daily or weekly, and finally, the number of sex workers who visit the site in the morning, afternoon, evening, or night.
Looking at the site analysis, really, it means that we want to try to understand each and every hotspot individually. Remember, the site map was more of a blanket. But now within this blanket, you want to pick one of the hotspots and analyze that particular site. Most of the key populations undergo probably a lot of violence. And it's through site analysis that you're able to tell this is the characteristics of this particular hotspot, and probably violence is prevalent within this particular hotspot, and maybe we need to have a paralegal person just to respond to the needs. And then also the other thing, also just to understand the frequency in terms of how often do the peers visit these hotspots and at what times do they visit these hotspots. So when that is considered, then also you're able to tell which is the best time to reach out to the peers within these hotspots. But at the same time, it also helps you to really prioritize, so that you prioritize those hotspots that have concentration, the high numbers of key populations, and also prioritize now the individual key populations who probably are really at high risk. For instance, you might find a transgender woman who may also be injecting drugs, among other overlapping risk behaviors that we see across.
Site load mapping and site analysis are the first set of microplanning tools. They offer an important foundation for outreach planning and, most critically, help location-based planning and monitoring. Microplanning rests heavily on community outreach, making it very important that programming is community-led and community-centered. This community-first approach would be impossible without a way to list and keep track of connections within a site. The use of contact listing and contact forms makes this possible. With contact listing, peer educators or volunteers list out the members of key populations they know from their social networks in each site. Contact listing helps participants map out their contacts with their peers within the spots they are responsible for. These lists are then combed over to check for duplication. Based on the number of contacts peer educators or key population volunteers have, the one with the most contacts and a larger social network is allocated that site to manage. In the case of key population volunteers, the volunteer with more contacts may be identified by the program as the peer educator for the site. This way, a peer educator becomes responsible for the site that they know best. It is also recommended that peers in the site should also be consulted before recruiting a peer educator for the site to ensure that the decision is acceptable to the majority of peers in the site.
What you do when you want to go about the contact listing is, as an outreach worker, you sit down with a microplanner and they have a list of the key populations that they want to put in their contact list or in their hotspot diary. They need to know these individuals or these key populations to ensure that they are able to tell them about the clinic, also to give them commodities. So what happens for us at times to have a duplicate of an individual? We have clinics that are in different towns and in different cities all over Zimbabwe. Say I'm a key population, I get a service in Bulawayo, and I lose my sister's number that gives me access to get clinical services in Bulawayo. When I move to Harare, instead of me mentioning that I once got a sister's number in Bulawayo, I'll just say I'm new, I've never been to the sister's clinic before. Then another thing that happens is on a hotspot, I did not know that my friend is a microplanner and I had already been listed by another microplanner. Now for me to tell my friend that I had already been listed, I'll pretend as if I had never been listed. So now I'm appearing in the other microplanners hotspot list, and I'm also appearing in my friends hotspot list. Those are some of the scenarios that can make us to have duplicates of an individual.
Once allocated a site, a peer educator is entrusted with a unique responsibility to approach the key population peers within the site and get more information about them. To do this, the peer educator first establishes a rapport with a key population peer or member and explains the program to them. Once the key population member gives their consent, the peer educator fills out a contact form detailing their contact number, the primary site they can be found, their age, risk profile, and other ways they may be vulnerable. While the data in the contact form is used by the outreach team for outreach planning, the information is also used by the monitoring team to register a key population into the program and provide a unique identification number through which they track the program services provided to the individual key populations across the continuum of services provided by the program.
Ndichomwe ndimakafika pa hotspot pamene ndimalembapo dzina lawo, zaka zawo, dzina la bala pa kuti akupezeka pa bala kapena ndi kunyumba ka ndi paloji ndimayenda ndilembe, komanso ndimalemba chiopsezo chawo kuti ndichochuluka bwanji, komanso zaka zomwe akhala akugwira ntchito yoyendayenda, komanso ndimafuna ndilembe kuti iwo aja akugona ndi anthu angati pa sabata. Chiwerengo chawo cholinga choti ndikamabweretsera makondomu ndabweretsere ndikudziwa kuti anthu aja akugona ndi anthu mwakuti kuti makondomu aja adzakhala kuti ani okwanira.
At times kuna challenge kwa sababu utapata for one siendagi na hiyo form. I go with a notebook so that kuna ile trust sione ninajaza vitu mingi, so natumia notebook kujaza, then I'll go and transfer them. For one, mtu atafikiria information yake unataka kuitumia wapi, but these are people that we know, we've known each other for a long time because I was one of them, I was a user, so they know me, so there's that trust.
Contact form inasaidia sana juu kuna mtu unaweza umemcontact leo, umekuwa sasa una details zake, alafu wengine wanajua crime nini, wanashikwa, wengine wamemigrate. Sasa hapo ndio sasa si kuja kujua, inasaidia kujua huyo alikuanga hapa siku hizi yuko maeneo mahali pengine. Sasa tunakuja kujua sababu ni gani, na kama kuna kitu tunaweza saidia, at least akuange tu yuko karibu na mahali anaweza pata hizo services. Sasa contact form inatusaidia sana.
These population-specific tools begin the steady and integral work of building links with individuals within a site. They are an organic way of building and sustaining information networks across program sites. To plan for anything, you need data, hard numbers that answer difficult yet necessary questions. What, when, how many? Without these numbers, planning becomes impossible, a kind of groping about in the dark. In microplanning, peers are responsible for the accurate collection and recording of these data. They are able to do this by using a peer plan and a peer calendar. A peer plan is a tool used by the peer educator which helps them account for the key population cohort they are responsible for based on the profile, risk, and vulnerability of each key population. A peer educator begins by listing out the key population cohort they are responsible for. Against each key population, they list out their profile, including their age, the average number of clients they see per week, or number of injecting episodes per week, if the key population experiences violence, or if they have a problematic alcohol use. This information then helps the peer educator develop a monthly plan for the individual key population based on their needs, including the best outreach times and days and the intervals between follow-ups.
The peer plan simply is a tool that helps us in planning for the activities that we require to provide to the peers at the hotspot level. It is essential in that it gives us the location of the person that we are providing the services for. It gives us the projection for commodities that they might require. It helps us keep track of what we are giving out.
Peer plan yakatibatsira kozi vasikana vakuwa nayo peer kwawanda kubva kwatiri ava sisina kutya mavari vanokwanisa kuyotaura maproblems avo and iyo risk yavo yavanenge vari whether uzoti irisk yavo iri pahigh low or medium. Saka ukaramba uchimushanyira uchitaura naye nguva nenguva zvino risk yake inoita chidzika. Zvaanenge achida zvese unofanira kunge wakuziziva kozi vanhu vaunenge wagara uchishandawo navo. Saka zvese zvaanenge achida unenge wakwanisawo kuita sei kuvabatsira nazvo. And izvozvo zvinoita kuti microplanning yedu irambe ichienda mberi. Kozi basa redu rikafamba ivo vakaonawo zvavanoda vakafarawo basa redu rakwanisa ramba ichienda mberi.
The plan essentially sets the stage for the peer calendar. While the peer plan collects data from the contact form to develop an individual profile of the key population for planning outreach for the week or month, the calendar documents services provided during the week or month. It offers a bird's eye view of the services that a key population member in the peer educators cohort has received, and if the plan developed using the peer plan was followed. This informs the level of support allocated to each key population in a peer educator cohort in a week or month. The peer calendar also facilitates discussions on challenges in implementing the plan made for the cohort and support needed by the peer educator in addressing these challenges. Some of the information documented in the peer calendar includes the number of condoms, lubricants, and needle syringe kits provided to the key population, the health education sessions conducted, violence support provided, referrals made to the clinic, and any other relevant information.
The peer calendar now comprises the left-hand side has now the peer plan, which now captures the bioinformation of the peer. Then, when you go now to the right-hand side, it contains now the commodities and the services that are delivered. It will have a column on needles and syringes. It will have a column on condoms, lubricants, and then the furloughs. It will have a component of health education, and then the clinical services, just to keep track of those that have been referred now probably to the drop-in centers by the peer educator. We keep track of who has come so that we are able to prioritize when we are planning for those who have not received any clinical encounter with our service providers.
Microplanning is first and foremost data-driven and community-led. The backbone of these two attributes is the peer plan and the peer calendar. As we conduct our community-led outreach in the key population programs, we need to continuously assess if we are leaving a site or specific key populations within those sites behind. That's why the last tools in the microplanning bag is gap analysis, reviewing peer performance for collective improvement. The last two tools used in microplanning are A. Outreach summary tool, and B. Opportunity gap analysis. The Outreach Summary tool helps the outreach worker to consolidate the performance of the peer educators who they support. This consolidation takes place on a monthly basis. This consolidation through the Summary tool helps in also conducting opportunity gap analysis for each peer educator. The analysis assesses a peer educator's reach against the population size estimates in the specific site that the peer educator is responsible for. Assessing the number of key populations actually reached by a specific service vis-à-vis the expected number that the peer educator should have reached helps to highlight the gaps and informs the support needed to address them. Each month, the outreach workers sit with a group of 5 to 10 peer educators and conduct this gap analysis. Each peer educator reviews the past month's activities, comparing their target to their achievement, which forms the core of the analysis for their assigned key population cohort. This tool is a way to identify where performance needs improvement and to determine whether targets are realistic. Some of the activities assessed include one-to-one contact, registration, condom or needle syringe distribution, HIV testing, and clinic visits. All these activities are assessed against the targets and gaps identified. The reasons for the gaps are discussed and opportunities and solutions identified to address them. This also helps the outreach worker to identify which site and peer educators need more support and plan for support based on the gaps. This process also facilitates cross-learning among peer educators as they share reasons for gaps and recommend solutions.
Opportunity gap analysis is able to help a peer educator really to understand in terms of the number of peers within a particular hotspot that are located and how many are being reached with services. For instance, how many are being contacted, how many are being provided with preventive commodities such as condoms, how many are receiving clinical services. And based on the denominator, which is actually the estimate of that particular hotspot, then you are able to really look into the gaps at the different levels. What may prevent peer educators and outreach workers from achieving their targets based on the experience on the ground is that at times you find that there are few programs that you still see high peer educator to peer ratio. Because as a country, we have set standards in terms of how many numbers of peers that a peer educator is supposed to reach out to. And it is across all the typologies. We have a set peer ratio for female sex workers, and it goes down to even the transgender people. What we do is really to advocate with development partners in terms of the funders. So it's a lot of advocacy that is being done at donor roundtable meetings just to show them, look, these are the peer ratios that you're having within the programs. And we all understand really the importance of peer education and outreach within the programs. Could we see how we could at least give more resources to the implementing partners so that they're able to hire more peer educators? But at the same time, where there are gaps within the counties, then also the country has measures in terms of also finding other donors who could be able to complement.
How do you account for the ones left behind? You plan for them at the smallest level. Microplanning is generating and using data at the site and individual level to deliver services to populations with the greatest need. The simple tools are meant to empower the peer educators and outreach workers to collate and use this data for planning and monitoring. At every stage, from site mapping to site analysis to contact mapping, the use of contact forms all the way to peer planning and calendars, and finally gap analysis, microplanning relies on the trust and confidence that a peer educator gains within the key populations communities they work and support. Everyone involved in microplanning understands that it's a system reliant on the highest level of data safety. Key populations are criminalized in most countries, hence a microplanning approach that generates maps, data, and information should take care of people's confidentiality and safety. Microplanning functions best when integrated into larger key populations programming and becomes part of a continuum where data collected can be routinely validated and inform decision-making.
One of the highlights is how easily adaptable these tools are. These tools use more visuals, more numbers. It doesn't need any high literacy levels. Even if the context changes, these tools are very adaptable to make it context specific. So the fact that it has been implemented in multiple countries with multiple subpopulations just shows that every country, every subpopulation can adapt it.
For Malawi, this is the model that we're using. I can tell you that for Malawi, HIV prevalence amongst female sex workers is very high at 49.9%. When we started implementing this model, we were able to reach out to many targeted population groups. As a country now, we have managed to reach out to test over 90% of female sex workers, and also we know that almost 90% of female sex workers who are living with HIV are on treatment. We managed to do that because of this model.
In India, when we did the evaluation of microplanning, what we realized is that higher number of hotspots were covered post microplanning, and higher number of populations in those hotspots were reached by peer educators post microplanning. But the other things that happened also was that the peer educators and outreach workers felt more empowered. They felt they had the capacity and tools to engage with their community and provide a more targeted and more differentiated outreach and service program for the key populations. So it increased ownership, it increased accountability of the program, but at the same time, the key populations and the sex workers and MSM and the drug users who were working with the outreach worker also felt more part of the program because they were engaged in the process of using microplanning tools.
If there are 1.4 billion people in Africa and we count ourselves responsible for the welfare of all of them, then can there be any group too small, too peripheral to program for? No, there can't.